Swayam Prabha. Digital India. Educated India.
Today we will talk about the diseases of the parathyroid glands. This is one of the gland which is not controlled by the pituitary glands. As we know that most of the endocrine glands, they have a control from the pituitary which releases some hormones which act on the target hormones and releases another hormone which act on the target organs. But this is one of the exceptions of the endocrine glands. Parathyroid glands are not under the control of pituitary glands. Normally there are 4 parathyroid glands, 2 upper pairs and 2 lower pairs. All 4 lies behind the thyroid glands. So we call them the right superior, left superior, left inferior and right inferior gland. Normally there are 4 glands, but there can be more than 4 parathyroid glands, and many times they may be at ectopic positions. They are far away from the normal positions, and sometimes when they are diseased, then usually not suspected, or sometimes pathologically very difficult to diagnose at the ectopic locations. As we know that each parathyroid is composed of 2 types of cells. One are the cheap cells or principal cells, or what we call as the clear cells. The clear cells are mostly seen in infants as normal, but normally in the adults they are absent except in some of the diseases. The other types of cells are with the more eosinophilic cytoplasm, which are known as the oxyphil cells. Both types of cells, they secrete the parathyroid hormones, which maintain the calcium levels, and it mainly acts on the bone, kidneys, and intestine. This is the normal parathyroid gland, which is composed of the fat, interspersed adipose tissue, and in between these bluish looking nuclei, they are the parenchymal component of the parathyroid. These are the clear cells and they are the oxyphilic cells. Oxyphilic cells, they have a more eosinophilic cytoplasm, whereas the clear cells, they have very distinct cellular outlines and the cytoplasm is almost empty. Now this shows how the calcium level is maintained. Whenever there are low calcium level in the blood, the parathyroid hormone is released from the parathyroid glands, which mainly acts on the bone, kidney and intestine. And from all these sources, it mobilizes calcium. From the intestine, it enhances the absorption of the calcium. From the bones, calcium. And from the kidney, it decreases the loss of calcium from the urine. And all these actions lead to the increased level of calcium in the blood. In the bones, the parathyroid hormones that activate the osteoclast, therefore it causes the mobilization of calcium from the bone. It is mainly the remodeling of the bones. In the renal tissue, it increases the calcium reabsorption from the tubules. It also increases the conversion of vitamin D to its active dihydroxy form, which is involved in the calcium metabolism. It increases the urinary phosphate excretion, thereby causes the more resorption of the calcium from the tubules. It also increases the calcium absorption from the gastrointestinal tract. Now mainly the diseases of the parathyroid, there is hyperfunctioning of the parathyroid hormone, or there may be the hypofunctioning. In the hyperfunctioning of the parathyroid glands, the PTH levels are raised, whereas in the hypofunctioning, the PTH levels are decreased. And predominantly there are three causes of hyperparathyroidism. One is the primary, other is the secondary, and third is the tertiary hyperparathyroidism. Hypothyroidism is extremely rare, and the most common cause of the hypothyroidism, that is the decrease of the parathyroid hormone levels in the blood, is after the thyroidectomy. When the thyroid gland is removed for one reason or other, many times these parathyroid glands, they are embedded in the thyroid tissue or they are behind the thyroid tissue and very difficult to identify during surgery. So they are also removed, and that is the most common cause of hypothyroidism, so-called the iatrogenic hypothyroidism. The other rare causes are the autoimmune diseases, some congenital diseases. In autoimmune diseases, there is one syndrome which is characterized by the hypothyroidism, the primary diabetes mellitus, and Addison disease, pernicious anemia. In the congenital, as we know that the parathyroid gland, they develop from the pharyngeal arch. So some of the congenital defect, where the thymus is also developing from these pharyngeal arches, and one of the syndrome is known as the Dye-George syndrome, where there is congenital absence of thymic gland and there are some cardiac defects. Now, how the hypoparathyroidism manifests? Most of the time there is cataract, calcification of the basal ganglia, and some dental abnormalities. Whenever calcium levels are decreased, there is an increased neuromuscular irritability, muscle spasm, tingling, facial grimacing, sustained corpopedal spasm, tetany, cardiac arrhythmias, and seizures. And most of the time the cause of death is cardiac arrhythmias, seizures. Now the hyperparathyroidism, the most common cause is the primary hyperparathyroidism, where the disease is in the parathyroid glands. Adenomas are the most common cause. In almost 85 to 90% of the cases, there is adenoma of the parathyroid gland. Hyperplasia comprises about 5 to 10% of the cases, and the carcinomas, they are less than 1%. They are very rare. Adenomas are the most common neoplasm of the parathyroid gland. They may be sporadic or they may be the component of multiple endocrine neoplasia, which we will discuss later on. Secondary hyperparathyroidism is a disease where there is a chronic hypocalcemia, and there may be some reason in the renal, there may be kidney failure, and which leads to the secondary hyperplasia of these glands. And whenever these secondary diseases are corrected, the parathyroid levels goes down. There is a peculiar situation which is known as the tertiary hyperparathyroidism, where despite the fact that the main etiological cause, for example, the renal disease is corrected or the calcium hypocalcemia is corrected, but one of the parathyroid glands becomes autonomous and continues to secrete parathyroid hormones, which causes symptoms. Now, parathyroid adenomas, as I told, is the most common cause. Most of the patients are between the 50 to 60 years. Females are more commonly affected than male, and mostly they are located in the inferior glands as compared to the superior gland. Nowadays, radiology has become very important in the localization of these parathyroid glands, as this localization is needed for surgery. The different modalities has its own significance, and mostly done are the ultrasound neck, system CAT technetium, 99 scintigraphy, computerized tomography, MRI is also employed for the localization of these glands. Parathyroid adenoma, they mostly involve single gland. That is very important to differentiate the causes of hyperparathyroidism, between the adenomas and hyperplasia. In hyperplasia, all the glands are involved, whereas in the adenoma, it is single gland involved. But it is also not very rare that there may be involvement of the two glands. In about 15% of the cases, they are double adenomas. That point to be remembered, most of the double adenomas, they involve the superior glands, both right and left superior glands. Microadenomas are the types of adenomas where size is very less. The size is less than 0.6 centimeter, or the weight is less than 100 milligram. Most of the symptoms, the bones are commonly involved, and there are studies which have shown that the symptoms related to the bones are directly proportional to the weight of the gland. Cystic change in the adenomas is very important, and many times there are adhesions because of the cystic change. Therefore, some of the adenomas, while doing surgery, the surgeon may feel that because of the adhesion it is infiltrative and wrongly diagnosed as or suspected as the carcinomas. There are some variants of adenomas: oncocytic, water clear cell, follicular, lipoadenomas. All they have no clinical significance except from the pathologist's point of view, that sometimes, for example, the follicular adenoma may resemble the follicular adenomas of the or follicular neoplasm of the thyroid gland. So they all have the value in the differential diagnosis from close mimics. How to differentiate between the parathyroid hyperplasia and adenoma? This diagram shows that in adenomas, only one gland is involved, which is enlarged. In hyperplasia, all glands are involved. So in the older era, the most important diagnostic difference between the adenoma and the hyperplasia was the surgeon's impression during surgery. Most of the surgeons, previously they used to take biopsy from the other glands also, besides the enlarged gland. So during surgery, they used to send the frozen section, which may reveal the hyperplasia of the other gland. If they are normal, or the surgeons feel that the other glands are normal, only one is enlarged, that is the most important point to differentiate between the hyperplasia and adenomas. But nowadays, with the invent of this radiological technique, most of the lesions, they are localized based on the ultrasound finding, system baby technetium 99 scintigraphy, CT and MRI finding, 4-dimensional parathyroid computography, that is 4D CT. All these help in the localization of the lesions so that the focus parathyroidectomy is done in spite of exploring all the parathyroid gland. This shows the microscopy of the parathyroid hyperplasia. Whenever there is hyperplasia, the parathyroid gland is a lobulated glands. The shape of the glands is maintained. So when we examine the sections, these are the lobules of the cells. Whereas the adenomas, the grossly, the parathyroid glands become these globular. They grow in one direction. Whereas in the hyperplasia, all the lobules are hyperplastic. There is fat in between the cells, in between the lobules. And if you go to higher magnification or to see the electron microscopy, some of these cells which are clear cells here, they also shows increased lipid contents in the cells. So one of the most important differential diagnoses from the adenoma is the presence of fat inside the cells as well as between the cells, which is usually absent in adenomas. This shows the differences between the adenoma and the hyperplasia. As I mentioned, the hyperplasia, all four glands are involved, and it is the asymmetrical, maybe sometime asymmetrical involvement, which causes the nodal hyperplasia, which can be confused with the adenomas. But in adenomas, usually single gland is involved, rarely two glands are involved. When there is a increased secretion of the PTH levels, it suppresses the normal parathyroid tissue. So most of the time in adenomas, one gland is involved, whereas the others are atrophied. And the most important microscopic feature is the rim of the normal parathyroid tissue compressed at the periphery. These are some of the examples. This is the adenoma, where the one gland is enlarged. It's more globular, whereas the other glands are normal. Point to be mentioned, surgeons should be very careful when they are sending the specimen for pathological examination. Whenever there is enlargement of the adenoma of the parathyroid glands, the compressed parathyroid glands that is pushed toward the hilum. So surgeon should mark hilum with a thread so that the pathologist take the section, that is the section should pass through the hilum, and one can see the compressed parathyroid tissue. This is the normal compressed parathyroid tissue. This is the capsule of the adenoma, and this normal can be differentiated from the adenoma by the presence of these fat cells. And when we go to the higher magnification, these are the monomorphic cells, these are the chief cells, the cytoplasm is clear, and rarely one can get this combination of the both types of cells, oxyphilic as well as the clear cell. And sometimes we do get the thyroid tissue in the periphery, which is nothing but because of some degenerative changes, their adhesion with the thyroid tissue, and one should not confuse it with the infiltration by a carcinoma. We do MIB labeling index to differentiate between the benign and malignant conditions, and usually in adenomas, mitosis is less than 1 per 10 high power field, and the MIB labeling index is usually less than 4%, whereas in the carcinoma, it is slightly higher. Parathyroid carcinomas, they comprise about 1% of the all parathyroid hyperparathyroidism cases. Male and females are equally affected as compared to adenomas, where females are more common. They are 3 to 4 times more common than the male. Age ranges from 15 to 89 years, but mean age is 56 years. Most of the time, carcinoma, they are very symptomatic. They have very, very high PTH and calcium levels, and sometimes clinically they are suspected because the PTH level and calcium levels are very high. Most of the time, the adenoma of the parathyroid, they are not palpable, but 30 to 75% of the carcinomas, they are palpable, and grossly surgeon finds the adhesions and infiltration into the surrounding tissue. Parathyroid carcinomas are difficult to differentiate from the adenomas, and there is some criteria which has been proposed. There is some absolute criteria, and there are some features which are associated with the malignancy. The most important absolute criteria for the diagnosis of parathyroid carcinoma is invasion of the surrounding soft tissue. But as I mentioned, sometimes there is cystic change in the parathyroid adenoma, which causes adhesions with the surrounding soft tissue and can mimic as invasion into the surrounding soft tissue. The other features are invasion into the surrounding structures like thyroid, esophagus, and trachea. Vascular invasion, and point to be mentioned, to be remembered here, is that the invasion, vascular invasion, should be only when it is involving the vessels outside the capsule. Sometimes because of the knife artifacts, there can be vascular thrombi, tumor thrombi in the lumina of the vessels, which should not be interpreted as the vascular invasion. Therefore, it is very important to remember the vascular invasion. There should be attachment of the thrombus or the tumor cells with the endothelial cells, and it should be outside the capsule. Perineural invasion is also feature which is more in favor of carcinoma. The most important and definitive is when there is metastasis in the regional lymph node or the distant organs. There are some features which are associated with the malignancy which are suspected, or when they are present indicates that this can be carcinoma. One of them is the capsular invasion without the soft tissue invasion, mitosis more than 5, broad intratumoral fibrous bands, coagulative necrosis, diffuse sheets of small monotonous cells with high nuclear cytoplasmic ratio, or the nuclear atypia, and macronucleoli in many cells. This is one example of carcinoma. Look at these are the lobules of cells. They are separated by thick bands of fibrous septa, and this is very much indicative of carcinoma. Skeletal muscle invasion, thyroid invasions, they are all indicative of carcinoma. Now mitosis, they show the presence of mitosis, and the anaplasia also indicate malignancy. MIB labeling index is usually between the 8 to 10% as compared to the adenomas. It is usually more than 5. These are some of the examples. It is infiltrating into the surrounding soft tissue. This pleomorphism, lack of those fat cells. The triad, which is very important to suspect carcinoma, is the macronucleoli, more than 5 mitosis per 50 high power field, and necrosis. These all three features, they indicate carcinoma has to be ruled out. This is one example. This is the adenoma with cystic chain, and because of the cystic chain there are a lot of adhesions, and these adhesions, these cells, they appear as if they are infiltrative, but actually they are not infiltrative. So one has to be very careful in those adenomas where there is a cystic chain and it can mimic parathyroid carcinoma. This picture shows how the parathyroid hormones, they act on the different organs and what are the manifestation. Usually what we call as the moans, groans and stones. Because of these calcinosis, there is stone formation in the kidney as well as in the gallbladders, the bones, there is osteoporosis, there are fractures, there are bronze tumor, what we call as the cystic chain of status fibrosa cystica, and because of the calcium levels, if the calcium levels are very high, these patients are more prone to depression, seizures, and because of the peptic ulcers, there can be pain. There can be pain because of the gallstone. There can be pain because of the renal stones. This is one example where this is a so-called the bronze tumor. There are a lot of these spindle cells, osteoclastic giant cells, bone remodeling, and these are the cases which mimics the giant cell tumor of the bone. One has to be very careful, especially when there is giant cell tumor in the smaller bone, in the jaw bones. One has to rule out the hyperparathyroidism, which is a close mimic of these giant cell tumor of the bone. Now, most of the time, these parathyroid adenomas, hyperplasia, they are associated with some of the syndrome. Then the most common is the multiple endocrine neoplasia. When there is more than one gland is involved, it may be hyperplastic, it may be the adenomas, and carcinomas as compared to the adenomas or hyperplasia are rare in Amiens syndrome. Mainly there are 3, but recently there is another type 4 is also described. Amiens syndromes, Amiens 1 is characterized by P3, what we call as the parathyroid, pituitary gland and pancreas. All 3 glands, the organ which start from the word P, they are involved. These occurs in the younger age. There is multiple endocrine organ involvement. There can be hyperplasia, there can be adenomas, and as compared to the sporadic cases, they are more aggressive. they are multicentric and the chances of recurrence are more common. MEN gene is on the chromosome 11q13. It encodes the protein mannin, and it can lead to hyperplasia or the adenoma of the parathyroid glands, pancreatic islets tumor, and the pituitary adenomas. By the age of 20 years, more than 50% of the patients they manifest symptoms. In the MEN2, the chromosome it's a 10q11.2, and there may be type A, type B, and the most common is the medullary carcinoma of the thyroid. It's very important to diagnose this syndrome because most of the patients they die of medullary carcinoma of the thyroid, and this is the one condition where prophylactic thyroidectomy is indicated. They are associated with the pheochromocytoma. The difference between the 2A and 2B is that in the type 2B, the presence of mucosal neuromas and the morphinoid build of the patient is more common, and it can help in the differentiation from the type 2A. It is the germline mutation of the red proto-oncogenes, and most of these families they can be screened for the mutation of this gene. These are the different stages of medullary carcinoma of the thyroid. These are the normal C cells. Normal C cells cannot be appreciated under light microscopy, but if we do with the immunohistochemistry for calcitonin, one may find these few glands inside the membrane amidst these follicular cells. And in the MEN syndrome, this may be the diffuse C cell hyperplasia. It may be nodule formations. These are the micro and medullary carcinomas, and ultimately leads to the carcinoma, medullary carcinoma. Multiple endocrine neoplasia type 4. It is very recently described syndrome. It is autosomal dominant tumor syndrome. It is characterized by the germline mutation of CDKN1B gene. It is just like the MEN type 1. The only difference between the MEN type 1 and 4 is that in the MEN1, the average age at manifestation is about 20-25 years, whereas the type 4, they are usually after the age of 50 years. Otherwise, most of the organs which are involved are the pituitary adenoma, pancreatic endocrine tumor, the neuroendocrine tumor of the cervix, bronchus, stomach. All features are similar to the MEN type 1. It is just the presentation of the age and the gene which is involved are different. There is another syndrome which is known as the hyperparathyroidism jaw tumor syndrome. In this case, it's an autosomal dominant tumor disorder. It is characterized by the mutation of the gene CDC73 gene. It is a tumor suppressor gene. It encodes the parafibromin, and most of these cases, because of the tumor suppressor gene, there is loss of this protein which can be detected by immunohistochemistry. Most of these patients, they present with the hyperparathyroidism, usually at the age of 40, and some of these patients may have carcinoma or adenoma of the parathyroid gland. The another features, which is the presence of the jaw lesion, which are usually ossifying fibroma. There may be some uterine lesions, which may be in the form of the leiomyomas, endometrial hyperplasia, carcinoma, adenofibromas. These are some of the components of this syndrome, but hyperparathyroidism is the most important, and the involvement of the jaw, which is associated with the hyperparathyroidism. Now, the etiopathogenesis of the most of the disease, these adenomas, carcinomas, is not known. Many times they are associated with the MEN syndrome, but one of the mechanism is that one of the PTH gene, there is a pericentric inversion. This gene, this chromosome that gets broken and attached to the somewhere here near the cyclin D1, and because of this the regulatory function of cyclin D1 is lost, and it leads to the neoplasia of these glands. Thank you.